Hello, my name is Linu V. Koshi from Pushpali College of Pharmacy, Kerala. So, a very good evening to the respected dais and all the respected sirs. And a very good evening to all the audiences. I just have only one doubt. I just want to say that everybody, I want everyone to, the future scientists to study about human beings, the total construction of human beings. Because in that case, there will be no need for medicine. It's like genetic engineering.
You can be specific on your question.
Yeah, it's like constructing the things which are to be replaced. The disease caused in the human beings can be replaced. So we have to study about human beings totally. Actually, the lack of knowledge of human beings is a problem of all disease. Thank you.
I think the question which is talking about is genetic, gene decoding, human genome decoding, understanding diseases, and then trying to go about it. I think that's the question, and how medicines or other things can play a role in such a type of advancement in science.
Just remember a presentation that was made yesterday that in fact described most of illness to behavior, not to genetics. And if we can truly understand human behavior and understand how to change human behavior, maybe we would not need as much health care as we have. But nobody has cracked that nut yet.
Yes, Rich.
Good evening. I'm Priyakshta from Bangalore College of Pharmacy. Sir, Suresh sir, I have a question for you. Not a question, but PCI, Pharmacy Council of India, does it permit, as I'm a fifth year pharmacy student, I'm curious to know the next year internship. I'm really curious about next year internship. Does PCI allow us to go for internship or like training in the next year, 6th year, any abroad training program?
See, the internship program is 12 years period or 12 months period. And 12 year period would be good, but you will be ending up paying fees every year, remember that. So 12 months is good enough, and in that 12 months PCI has permitted that for a period of 3 months you can do this internship or rotation in other than your hospital where you are presently doing a full internship. It can be in India or abroad. Let us say if you have been able to find a 3-month rotation in say US or Canada, Australia, or any country, we can take that into your period of internship having completed. Or even within India, if you want to do it in say a specialization in cancer or cardiology in some other hospital, that also is accepted. So that provision has been made in the internship.
So one small question. Sir, what do you say to the institutions or faculty about the stipend for the students?
See, the council had earlier given a direction that the fees and the stipend confusion was there. Now we have given a very clear direction, the resolution, that every institution shall pay the stipend to the student in the 6th year of residency.
Yes. Next. Please give your name.
Good evening, Manandar. My name is Gokul Raj and I'm from JSS College of Pharmacy, Mysore. I have a two-step question. The first one is, The changes in curriculum that I felt personally as a student required is, in terms of the subjects human anatomy and physiology and pathophysiology, we expect that, or we felt that as students, if those subjects are taught to us by physicians, we'd have a better understanding of this.
Would you like to comment that the question is asking, can pathophysiology subject be taught by the physicians rather than the pharmacists or pharmacy practice teachers who are doing that? So what do you think is, do you share some of such thoughts which is happening in US or Australia?
I think early on, as your schools are adding additional clinicians to your faculty, it probably makes sense, and I think historically it was also the case in the United States, that some of the pathophysiology was taught by physicians, but now actually most of it is taught by the clinical faculty at the colleges of pharmacy instead, some by basic biologists, pathophysiology PhDs.
My answer was going to be similar in the initial stages. It's likely that until the clinical faculty within the universities can be increased, that may be necessary. But one of the other things to consider is to have interprofessional pathophysiology, so that the pathophysiology is taught with the other disciplines, so that you then get an understanding of everyone's knowledge and where everyone can contribute.
Suresh sir, would you like to make this as a regulation for the initial sound?
I'm going to answer that very question. I knew that you are going to ask me next time. See, now you decide that if we now we have put in the regulation that the pharmacy subjects to be taught by the pharmacy teachers with practice experience of pharmacology, pharmaceutics or the sciences. Chemistry we have defined that, so there is a mixture of sciences teacher, practice teachers teaching you various subjects. You are asking me now that whether we can amend that regulation and make the medical faculty to teach. It's an excellent idea. But I am going to tell 3 years later you are going to come and tell me, we don't have jobs. Why are you allowing medical faculty to teach us? I am telling the answer. So, nothing prevents us by value adding. See, we do that all the time. Whenever we have some medical subjects to be taught, we invite the physicians attached to our hospital where we are working, asking them to come and give lectures, and they are very glad to do so. For that, we do not have to have a full-time medical faculty coming and teaching you pathophysiology, because then after some time you come back and that I can teach this subject better, or I can do this, and you come back to us telling that we have to do away with this requirement. So now my recommendation to the managements or the deans or principals who are here is, you can always, you are all attached, many of you have medical institutions attached to you. I think definitely the faculty from the physiology department or pathology department would be very glad to come and give a few lectures. But for that we need not have to amend the regulation and do it. It can be value addition to whatever you are doing. That's what I want to say.
See, biochemistry is a subject in a medical course. So, biochemistry can be taught by only the biochemists more than the doctors. The knowledge of chemistry, basics, biology, sciences, everything, they have more knowledge. But all medical colleges is taught by medical, MD biochemistry, every year. Basically, they want the qualification every year with the MD biochemistry for the specialization. Similarly, in pharmacy also, you call pharmaceutical patho or pathophysiology. See, pharmaceutical. So after some time, initially when doctors were there in pharmacology department, dispensing was taught by only pharmacists. See, the dispensing is a subject which is not getting to them totally. But however, still, we are also equally involved in the partnership. That is why you are respected. Similarly, the partnership will always be there. There will be pathological laboratories, pathological scientists, pathological medical specialists. So we can utilize the services. You you can become an expert.
So the second part of the question is for the foreign guest. As you all have told that maybe 30 years ago it was the same situation that we are in right now. But the concept of health here is a bit different, I feel. Here the patient has to pay from his pocket for all the services that he takes care of. So for the patient, availing the drugs, availing the services of the physician himself is quite a burden. So who is going to pay a clinical pharmacist in this scenario? We do not have insurance companies also.
I would say that one of the primary impediments to the spread of clinical pharmacy around the world is the fact that the payment historically for what we do is a transactional payment for processing a prescription. And that's broken, regardless of whether it's paid for by insurance or paid for by the patient out of pocket. But what's changed is that we can no longer hide the fact that when drugs aren't managed properly, patients suffer. And somebody is going to pay to eliminate that suffering. It's either going to be the patient, it's going to be the patient's family, it's going to be the public sector, but somebody's going to pay because that's not hidden under a rock any longer.
I think also to add to that, it's very interesting because the payment systems, even in the United States, for the services of clinical services of pharmacists are not well developed. In some sectors, it's now well developed. But some of the very early clinical services that were provided by pharmacists was before there was any system of payment from the health insurers. The health insurers would not pay for those services. The pharmacists were charging for those services, and patients were paying for those services. So again, if there's demonstrated value for the patient, if they have to, they'll pay for it. And I think that was the indication in the United States that there are people who are willing to pay for it if it's not going to be paid for by insurance.
Yes, my comment would be similar in that when a pharmacist is involved in optimal medicines management, it's often the patient can actually save money because the medicines, the management is better and some medicines are not required. So I think that once you've actually identified that the pharmacist can provide that service, patients and perhaps insurers, governments will be prepared to pay for that service because they can see that the end result is better care for the patient, optimal medicines management, so therefore not overuse of medicines that shouldn't be used, and improved outcomes.
Mila, would you like to add a comment? Because you were just discussing with me on the other day how you started your career, where faculty appointed you in the hospital, and then you were providing the services. Then now, how many clinical pharmacists the hospital has appointed?
Thank you very much, Professor Suresh. First of all, I want to say again thank you for having me here. And this has been a wonderful experience. I've had a chance to speak with at least 150 students since yesterday. So thank you so much. As I said to them yesterday in my presentation, that when I started Children's Hospital, there were no clinical pharmacists. I was the only pharmacist. And now there are 13 pharmacists at Children's Hospital that are paid entirely by the hospital. At the medical center, we had only 3 pharmacists. Now there are 65 specialist or generalist pharmacists hired completely by the hospital. But it has to start somewhere and show the value that you provide. So I have no doubt that with this great start, that you will be able to demonstrate a value unequaled by any. So I wish you all the best. It is you have to start somewhere. As I said yesterday, that when I went to the hospital, the first question was, "Are you a PhD?" I said, "No." "Have you gone to medical school?" "No." "Then why are you here on the 6th floor? You should be in the basement." That's where it began. And my response was, "I'm just here to see where I can help." So the relationship, how you build the relationship is the key. It took about 6 months before they could see that I could contribute. So I wish you all the best. Thank you.
Namaskar to all members of all pharmacy. Sir, my name is Asif Singh Parihar from DVM College of Pharmacy. I am lecturer. So, sir, my question to you, as our respected foreign delegates inform us about preceptor training and lots of things. Sir, so when we are going to implement this in our India?
See, if you recall the slide which I put yesterday, the last one slide, we talked about training the trainers. So that is one of the major challenges which we feel at the pharmacy council. Yeah. So now we have created that opportunity, and we are looking forward that the institutions, the teachers and the preceptors would actively move forward now in that direction. Preceptor training and training the teachers to address these issues which you are talking about. And today there was a specific session for the preceptors. Discussion was there today this morning in this hall, and a few of the teachers, senior teachers who are present, I think they discussed these issues and are looking at it. From the Pharmacy Council of India side, we have set aside, as I said, certain resources for these training purposes. Now, the institutions, the teachers will have to come forward together to how they would like to advance and get their trainings refined and sharpened and more. Not that they are like, they need to know how it is. Any education in any country, when it is introduced newly, it has its challenges. I'm sure there was a similar experiences in US or in Australia, but that helped. Now, the Pharmacy Council of India has already made a provision for the preceptor training. They have said those teachers who are not experienced, they need to go through this training process. And we have identified also certain centers where they can go for such training, where the practice is good. And we are even ready to organize these activities. Only now it's for us as the fraternity of the pharmacy profession to take it up serious, aggressively. You would like to say about the similar challenges you faced there in the US, when you are in Australia, you started the program?
Making sure that there's enough preceptors is really job number one, and then closely behind that is making sure that they are prepared. Because being a teaching practitioner is different from being just a practitioner, there's no question about it. There is an online education system that's been developed interdisciplinarily in the United States. There's 8 modules in it, and one of those modules is specifically for clinical instruction. And so that's available broadly via the internet as just one example of a teaching resource for preceptors in the United States.
And our story in Australia is very much the same, in that the important thing is finding appropriate numbers of quality sites so that students get quality training in those sites. And that involves making sure that preceptors have the skills not just to practice and allow people just to see them to practice, but actually to actively teach and to teach the skills that are required. And we also have an online preceptor multidisciplinary preceptor training program to develop those skills in preceptors so that they have those teaching skills as well as the high level of practice.
And just to reassure or to do that, I would like to say that our colleagues from different countries and different organizations, we are already discussing about sharing certain resources, how we can help each other. And one of the ways we are looking at is how Indian Association of Colleges of Pharmacy can collaborate, partner and move forward. In fact, Peter was telling me this afternoon while we were having Peter Vlasis is there, he said collaboration leads to celebration, and that's what he said. It's not patented, so you can use it, he said. So that's what we are looking at. Can all this collaboration which we are talking about can help us keep to the direction, and really at some time we'll be able to celebrate the success which is there. So we are looking forward to such collaborations from the Indian Association of Colleges of Pharmacy. One second. Krishna Kumar, you want to add a comment?
Yeah, we are planning some modules. So there's going to be one, perhaps with the there are some modules for planned for preceptor training, and I think the first one, Dr. Patsati is somewhere doing the so we're planning one, and it will probably be delivered in the end of May, early June. Thank you. this professor and vice principal NDT Pharmacy College Raichur, sir. Because I asked this question in our last Pharm regulation workshop, sir. Whether our course content is validated by the other countries for pursuing higher studies or for appearing FPC, NAPLEX is the first question, sir. Second, why don't we go for grading system for our present Pharm course, sir? We have now, sir. Why don't we go for grading system?
You would like to talk about international validation of the program, right?
I will try, but I always get in trouble if I speak on behalf of the National Association of Boards of Pharmacy. So I can't honestly say at what stage they are in terms of their assessment of the curriculum of the PharmD. I'm sure it's been made available to them. It's not something that ACPE is responsible for. So I really should probably not speak on their behalf and don't have a clear answer yet in terms of where they are in that process. But I believe that information has already been presented to them. Hopefully they will make an announcement soon in terms of what their answer is. But I'm not aware that they've made any formal position in that regard.
Now, to add the supplement that, when we designed the structure of the PharmD program of the curriculum, we did send and circulate that to a few of our colleagues internationally and ask their inputs. That how do you feel that our curriculum would fit in the role and the positions based on our country's needs? Because we have to plan our PharmD curriculum strong enough in the sciences also, and also on the clinical trainings. That was a balance we were trying to achieve. For the reason that in the event the student in our country feels that he has to take a sciences path, he should not feel his training was inadequate and he has to redo the whole thing. So that is why we try to strike the balance. In fact, some of the comments that we got was why the sciences are so strong, along with the clinical practice was the feedback which we got, but when we explained, that was accepted, and that is how I feel. But right now, the Pharmacy Council of India has appointed a committee to review the present PharmD curriculum. We have received the feedback from various teachers, some of the students, they all fight together in the council. The curriculum committee is now again looking whether there is a need to fine tune what is to be done. And once we are there, we will definitely involve all our colleagues from different parts of the world and the globe to help us in the inputs. That's what we look at. Regarding accreditation or grading of the colleges, I think it's too early to move towards that. I think
is having only 1% of global market. Just 1% of global market giving thousands of job opportunities. If we capture more of this, then all the hospitals and all the pharmacy people, including even B.Pharm people, Pharm is the best suited for clinical trials or pharmacovigilance, which is being neglected.
Thank you, Srinivas Reddy. In fact, if you closely look at today's program, if you go out and see the poster there is a session at 8:30 to 10:30 in Neptune Hall, which was for the CEOs and other hospital stakeholders. I think Mike Venus was there. Would you like to add a comment, Mike? What was your impression? How did the session go in the morning? What is your feeling? Give the mic to. You were there, so I don't want to tell. You should tell what is your impression you felt at that time.
Yeah, my impression was from each of the stakeholders that were there. This included health systems, included clinical research, included industry. They all, I think, were favorably impressed with the potential that the clinical pharmacist brings. So, yeah, I think it was very positive. We didn't hear anything but positive remarks, and each of them had good things to say about how they thought they could use the clinical pharmacist in the future.
Frank, you two were there. Would you like to say?
Yes, I think there was a very definite positive mood, which I think all of the students should be very happy about. There is a sense in India that the time has come for this kind of approach to actually the problems of improving the use of medicines in India. And I am very optimistic listening to what I heard from some of these very senior people across India in different aspects of the healthcare industry. I believe you should be very optimistic. It will take time, of course, and so much is going to depend upon you as individuals working here in India with Suresh's final slide from yesterday in your mind. This is the mission, is to help the lady with the ox. Please don't forget her.
Thank you, Frank. So just to answer again broadly, the presentation which we made to the CEOs of the hospitals and the Indian Drug Manufacturers Association and all that, they have both the organizations, there is organizations of hospital administrators in Karnataka. They have said in their next meeting, they want us to make the same presentation to all their members, which is an association of all the administrators of all the corporate hospitals in Karnataka. They meet once in 2 months and they want us to make a presentation. They said you should make this known to everyone. So that is the impression they had. And the Indian Drug Manufacturers Association has said that they would like to make a similar presentation in their forum, which is going to be held again in 2 months' time, and they will give us 2 hours slot so that the industry across the country can know that there are clinically trained pharmacists available to them to do roles which, other than just manufacturing and analysis and quality control of medicines, they feel that you can definitely be a bridge between the products and the patient and the physician, and try to see that the right information reaches the patient as well as the physician. So this effort has been done this morning. Thank you.
Good evening, everyone. And my name is Kiran Majigari. I am from Sri Aishantini College of Pharmacy. My question as a student is specific to respected Indian pharmacy leaders sitting over there. At what level corporate hospitals and multi-specialist hospitals in India and the government of India know about our services? And what are the steps you have taken and in present, and what are the steps you have planned for future to promote us for our job providers?
The last question for President has answered for the question also. That today morning from 8:30 to 10:30, we have invited CEOs from various hospitals. The President of ITMA was there, and the pharmaceutical industry managing directors were there, and then the Deputy Director of Drugs Control of India was there. We have presented and enlightened and we told about our program to them. After that, we have taken their views. That views only our President has now it is known. they will create job opportunities for our founding graduates in corporate hospitals, retail enterprises. They are going to take up in few years of time. All our pharmacy graduates will be employed in India in various hospitals, medical research organizations, and drug manufacturing industries, and as well as in government of India by in pharmaceutical industry. Okay.
Sir, one thing. Provide community services, we need support from Government of India. About that, what do you say, sir?
See, for providing community services, I did not get the question. You mean to say participating in community health programs of the government? Yes, they are familiar. But how many of you are from which place?
So basically from Bellary, I am studying.
Bellary. Let us say, will you be ready to go and work as a clinical pharmacist in a small village in Bellary, that side, for the rest of your life?
Definitely, sir. If Government of India would provide us a job.
No, this is
Again,
not
government,
even
why
in
government
the
is- why
medical
government?
profession.
You require community.
See, medical profession, the greatest challenge for the government of India is to make the doctors to go to the rural areas and work. They have tried and failed. That is why they are looking at the community doctors to be trained and made available to them to go and carry out this type of responsibility. Participating in community health programs, implementing it, yes. But if you are looking at the government appoints you as a clinical pharmacist in a remote place, I am sure that post is going to remain vacant and nobody is going to go there. And it is going to create a negative impression of what we are doing. Let us do the roles which we can do and prove ourselves first. That's what I would like to say. If we spread ourselves thin, we will fall flat one way or another and the whole thing will start collapsing. This is my personal experience. And I'm sure they would all say, in fact, one of the points that we had in one of the earlier meetings where Mike and others were there, we presented a list of 10 different things we are going to do. Their thing is, yes, it's all excellent ideas, but how are you going to implement all those 10 things simultaneously? So I think we'll have to go one by one step at a time and reach it. The community health programs, yes, the government can think and see how we can partner with them and we work with them.
Okay, sir. For this